Hello, everybody, and welcome to the Thursday edition of Video Clips. And I guess this is a week where we're going to talk about cancer, but the inspiration for the research that I'm going to present to you today actually happened at our conference a couple of weekends ago when Dr. Tom Seyfried was talking about cancer and the terrible outcomes for many different types of cancer. And he made the statement that often biopsy causes the metastasizing of cancer. And I had heard this before, and I remember seeing an article not a few years ago and thinking someday I really need to look into this and see how serious this is and how often it happens and write a paper about it. So this provoked me to start doing that. So here goes. Patients with cancer die of metastases, and this often happens after receiving what are considered successful treatments like surgery, chemotherapy, and radiation. And many times cancer patients are told, oh, you're cancer free, but it doesn't last very long. So oncologists often tell patients that the reason cancer recurs or metastasizes is that the cancer cells were scattered around the body and they weren't detectable before treatment began. But a growing body of evidence is showing that metastases might be due to diagnostic tests and treatments that disturb the tumor environment. And when I started looking into it, I was really kind of shocked about how much I was able to find on this issue. It's not like it's a big secret out there. Biopsy is a standard part of diagnosing cancer in order to determine the best treatment. And there are many different forms of biopsy. You can do a partial or complete removal of the tumor, that's considered a biopsy. It can be performed, biopsy can be performed via core needle biopsy or fine needle aspiration. The problem is that whatever you're doing, it's pretty easy to dislodge cancer cells from the tumors, which sometimes results in metastases. Once dislodged, the cancer cells can travel to nearby blood vessels via the interstitial fluid into the lymph system. The other risk is tumor seeding, which means that the cancer cells are dragged out along the needle track, causing cancer close to the original site or metastases into distant sites. Cells dislodged during biopsy or other procedures are referred to as metastatic seeds or circulating tumor cells, CTCs. CTC levels are higher in patients with metastasized cancer. They're associated with poor prognosis and higher mortality rates and are predictive of the progression of metastatic cancer and predictive of whether or not treatment will be effective. Most CTCs die, but a small percentage of them, enough of them to cause a lot of problems, survive, and they take up residence in the bone marrow and other places in the body, avoid the effects of chemotherapy, remain dormant for months and sometimes even several years, after which they can become aggressive and develop into full-blown cancer. About 62% of breast cancer patients experience recurrence after the 5-year benchmark. 5 years of survival from diagnosis is the benchmark of success, and die of cancer due to recurrence and or metastases. In a study conducted at John Wayne Cancer Institute in Santa Monica, researchers identified 663 patients with biopsy-proven invasive breast cancer who had sentinel lymph node dissection. Patients were biopsied using fine needle aspiration, large gauge needle core, or excisional procedure. The incidence of sentinel node metastases was about 50% higher in the women who had fine needle or large gauge biopsies compared to women who had an excisional procedure. The researchers concluded that this was due to mechanical disruption of the tumor by the needle used for biopsy. A research group at University Hospital in Lund, Sweden, reported 5 cases of percutaneous tumor seeding in the fine needle biopsies of abdominal malignancies. The researchers concluded that the procedure, meaning biopsy, should only be performed when it is absolutely necessary in order to determine treatment options. 2 cases of tumor seeding, one in a liver cancer patient and the other in a colorectal cancer patient, were reported by researchers at the Department of Surgery at the Royal Infirmary in the UK. They wrote, quote, "The risk of needle tract recurrence of liver tumors should not be regarded as insignificant. A patient with hepatocellular carcinoma had a fine needle biopsy followed by surgery to remove the tumor and subsequently developed another tumor at the insertion site of the biopsy needle. Analysis of the second tumor after surgical removal showed that the second tumor was metastatic cancer that came from the first tumor. A review of 59 patients with hepatocellular cancer who underwent percutaneous needle biopsy as part of their diagnosis showed that 3 of them developed cancer along the needle track in the soft tissue and rib area. One of them required lung resection in order to remove the metastasized cancer. The researchers wrote, and this is a quote, "Percutaneous needle biopsy of suspicious hepatic lesions should not be performed indiscriminately because there is significant risk for needle track implantation." So already, I mean, I'm not finished yet. You're seeing there's a lot of evidence that suggests this. Analysis of data in patients who had liver resection due to colorectal cancer that had metastasized showed that 17% of them had evidence of tumor development along the needle track from biopsy. Survival rates were worse in patients who had biopsies than for patients who didn't. The researchers concluded, quote, "Biopsy of metastases confers poorer long-term survival in patients after liver resection and cannot be justified in patients with potentially resectable disease." In other words, what they're saying is just take it out if you have to, but don't biopsy it first. Case reports describing similar outcomes have been published in medical journals for parotid tumors, mesothelioma, squamous cell carcinoma, thyroid cancer, non-small cell lung cancer, head and neck cancer, and oral cancer. Needle biopsy can also stimulate distant metastases due to inflammatory molecules that are produced in response to the wound that is induced by the biopsy needle itself. Other types, and this is where it gets really disturbing, other types of mechanical force can also cause cancer metastases. In one study of patients with colorectal cancer who had no circulating tumor cells before colonoscopy, 14% of them had detectable CTCs after the procedure. And of course, colonoscopy is routinely done in order to diagnose and develop treatment plans for colorectal cancer. Any surgical procedure can actually cause the release of CTCs. After tumor removal, the surgical bed can contain blood, extracellular fluid, and inflammatory cells like cytokines, creating a welcoming environment for stray cancer cells and promoting the entry of these cells into the lymph system. Many studies have shown that CTCs increase during and after surgical procedures, which means that the surgery itself may lead to metastases in some cases. One of the mechanisms of action is that wound healing stimulates angiogenesis, which promotes tumor growth. The National Cancer Institute, I was shocked to find this, but it actually acknowledges that both surgery and biopsy can cause the spread of cancer, but says that the risk is extremely low. Now, the reality is we really don't have a quantification of the risk. Not enough research has been done, and I think part of the reason is because very few places would have an appetite for proving that cancer treatment causes metastases. The number of studies, however, and case reports concerning this issue seem to indicate that the incidence is higher than previously thought. Some research groups have pointed out the risk is not insignificant. There are known mechanisms of action which strengthen the findings even more. Most doctors are not aware of this, most patients are not aware of this, and biopsies and surgical procedures are really common in cancer care. Many of our members have been told that they couldn't be cleared to have surgery unless they consented to a biopsy, because I've always thought that this was kind of a bad idea. I've never met a single person during the last 25 years who knew that there were risks associated with the procedure. It's impossible to quantify, as I mentioned before, but it is quite possible that many people who've been treated for cancer would probably be better off if they'd been left completely alone or pursued alternative options, and might have opted to do so if they had known the risks of even diagnostic tests to quantify and look at the cancer more. So to be clear, I'm certainly not suggesting you never do a biopsy. To be clear, I'm not suggesting that all cancer surgery is bad. What I am suggesting, and I do continue to discuss week after week, after month, after year, is the necessity for people to be informed about the risk. And they're not. And one of these days, and before I leave this planet, mark my words, I will have somehow, not sure how it's going to happen yet, but I'm confident that it can be done where laws would be passed where this type of information is required to be put in front of patients when they're making decisions about treatment, because I really think it's important to do that. All right, that's all for today and all for the week. Keep the emails coming about Nutrition Educator conference videos, professional training with us. I talk to a lot of you on the phone every week. I enjoyed the interchange, and I know that I've helped some of you get some direction about what to do to help out with these kinds of situations and make sure that people are